Uh, this is Dr. Tom Rafai. I am the editor of NOTeD, News of the Day, brought to you by the True Health Initiative. We love to bring top-level experts in nutrition and lifestyle to you, directly to the public, and honored today to bring a hero, really to me, someone that helped train me when I was a resident in the Beaumont Health System, and who is over and above that, a highly respected leader, and now an advisory council member to the True Health Initiative, Dr. Barry Franklin. Thank you so much for being here.
Dr. Rafai, pleasure to be with you.
Thank you so much. He is a director of Preventive Cardiology and Cardiac Rehabilitation for the Beaumont Health System in Royal Oak, a phenomenal hospital that I frankly was born at, not just trained at. Little trivia point there. Over 1,000 beds. It's a truly magnificent and large facility that, and the system in general, and of course that's the heart of the system, the original hospital, Royal Oak, was #1 this year in the U.S. News and World Report for cardiology and cardiovascular services. Congratulations.
In Michigan, correct.
Michigan,
yes, thank you.
In Michigan.
Yeah.
And you know, with University of Michigan #2, we love, you know, I'm you know, as a Spartan, I have no problem with Wolverines. I think they taste great. Excuse me, I misspoke there. Sorry, little Freudian slip. But you know, with all due respect, all around, excellent services both, but not enough people know the quality of cardiovascular and cardiology services at Beaumont. So thank you. Congratulations there. Also past national board of director member for the American Heart Association. Yes.
Yes, correct.
And past president of the American College of Sports Medicine.
Correct. As
well as current board of directors member for the American Society for Preventive Cardiology. I think, and with a PhD in physiology from Penn State and such a phenomenal career, I think everyone, you should know what you are going to hear from Dr. Franklin is something you should take very seriously, although we will try to have some fun in the process.
That's fine.
If that's all right with you, sir.
Sure.
So I think I have to honestly ask one question that really has been a challenge for many, including myself, and it comes down to what you know, Dr. Katz, our founder for the True Health Initiative, would call total harm reduction, right? The management of total risk. You're really not going to get to zero risk in anything, whether it's driving or otherwise. Mm-hmm. And that is that in retrospect, we're not judging what happened, but in retrospect, if we had a chance to go back, or something similar like this happens again with a disease like COVID-19, which tends to prey on the type of people we're most concerned about with cardiometabolic risk and so forth. Was it a decision you would, in retrospect, do if we had a chance to repeat it, to close cardiac rehabilitation center and gyms that were run within hygiene protocols, as long as we did? What is your perspective on the benefit versus risk of the value of that of the facilities in terms of exercise and its role it plays in cardiometabolic health?
My perspective is that you've got to weigh the risk-benefit ratio. And from my perspective, when COVID hit, uncertainty abounded. We still are uncertain in terms of who's contagious and so on and so forth. We're talking about a very high-risk group. These are all people post-MI, post-bypass, some with compromised ejection fractions. So I don't think it was unreasonable to close programs at the time. We came to the sobering realization that people were far less physically active. The literature would say 30% less physically active, 33% more sitting time. So that period of time, if people did nothing, yes, for the 2 months or so, their fitness decreased. On the other hand, we're talking about a really high-risk population who many were not vaccinated early on. So for all those reasons, I still would have closed those facilities. For your information, many other programs, including ourselves, now can offer virtual, exactly what we're doing, monitoring patients and so on and so forth, virtual programming. And in the future, if this happens again, we're going to offer virtual programming and stay in better contact with our patients. But I wouldn't fault that decision.
So there's a silver lining there, that this, while there was a lot of movement towards telehealth and so forth, the pandemic certainly pushed us in a direction where we can take heart in one point of silver lining, that these type of services can, even without a pandemic, be leveraged by those who might not be able to get to a destination program, but also certainly help in terms of any future scenario where we might have to close such facilities.
I'd agree with that 100%. Yep.
And I think though somewhere in there you were saying though that it's inevitable that there was some price to pay, that people did become less fit, and that's not something to necessarily shake a stick at. We had to come up with a virtual program. We didn't want to just simply let it go and think it's a window dressing, people exercising for recreation. Well, that's fun, and I think we all agree as much activity as you can get that doesn't feel like exercise is great. It has a very serious effect in terms of sedentary time and losing maintenance of physical fitness.
Yeah, I would agree with that. You know, the classic study, when you talk about losing physical fitness, was one done, and I'm sure you're familiar with this, by a guy by the name of Bengt Saltine, where he took 10 guys, had them bed rest for 21 days and measured their aerobic fitness, and it decreased about 30%. As you well know, that's the equivalent of decrease that normally occurs over 30 years. So in many respects, bed rest per se, and these people weren't bed rest, but bed rest per se is a time machine. It accelerates the aging process.
Absolutely, 100%.
Yeah.
Now, one of the measures that you use, and we'd like to see if we can get the public, you know, and there are some scientists that might watch this, but largely this is a very smart lay audience that we're talking to here. Mm-hmm. When you do certain types of cardiometabolic testing, I'll even call it that, maybe to distinguish it from classical stress testing, you use a term called metabolic equivalence. And could you somehow translate that in any way that makes it so that people want to know what theirs are, what it might be, and in terms of practical language, what they can do to stress test themselves, I guess, in a way to guess, if they don't actually have a test that's done by Dr. Franklin or others that determines their specific metabolic equivalence?
Yeah, metabolic equivalents are also called METs, and they're units of energy expenditure. So you and I, during this conversation, people at rest are typically at 1 MET. Everybody is at 1 MET. We now know that when people do physical activity, their energy expenditure increases. So if you're walking down the street, Dr. Rafai, at 2 miles an hour, you're working at 2 METs. 3 miles an hour, you're working a little over 3 METs. If you're playing singles tennis and you say to me, Barry, I want to play singles tennis, what is it? We know it's about 6 to 7 METs. Jogging at 6 miles an hour is about 10 METs. So we use METs to quantify energy expenditure. And I use it as a clinician because if you are my patient and you say to me, I want to start playing singles tennis again, or racquetball, let's say racquetball, 8 to 9 METs, and we've done a stress test on you and you got a 7 MET capacity. What would I say? I'd say, Dr. Rafai, you may be able to do that at some time in the future, but right now this would require a supra-maximal effort, getting your heart rate very, very high levels of oxygen consumption. So we use it to prescribe exercise as well as quantitate or quantify fitness, and we compare fitness versus the anticipated activity and come up with objective recommendations. Make sense?
Absolutely. And in a sense, let's go back to what it sounds like to me is your body's capacity to burn fuel, whether you have and particularly, I don't want to be playing singles tennis, or it's definitely racquetball with a 4-cylinder engine. I want to go in with a Chevy 454. I want to have something that can burn some METs. And in that sense, as a gas guzzler, I guess it's a good thing, because we're talking about burning calories and ultimately, spewing out some water and carbon dioxide. And whether you've got a well-running, stronger motor or not is what METs can tell you. Is that?
Yeah, I'd agree with that. And the other thing is, from a physiologic standpoint, when people say what determines it, cardiac output, the amount of blood your heart pumps per minute, and arterial venous oxygen difference. And believe it or not, there's not a big difference from one person to another in arterial venous oxygen difference. So in many respects, the oxygen consumption is a good index of heart pump function or cardiac output. Clinicians know that.
Okay, yeah, yes. And so there's not so much more oxygen that can be extracted in someone who's in shape versus not in shape. Maybe a little bit can be, but it's more about
at their level of their muscles. There's not a huge difference from one person to another. Big difference in cardiac output. Some of the elite athletes we see are 35, 40 liters at maximal exercise, and some of the heart failure patients are 5, 6 liters, something like that at max exercise. So big difference.
Since we brought that up, and a friend of both of us, now I'd say a good acquaintance for me, a good friend of yours, Dr. Chip Levy, was talking a bit on the extreme end. Maybe we'll just touch on it for a moment of where it might be. And clearly we have too little physical activity in America. Everyone who's listening, please don't take what I'm about to ask Dr. Franklin and think that you should do less physical activity. But on the extreme end of marathon running and triathlons and where you might get into heart restructuring that's really large because of are significant because of the volume demands of physical activity, for instance, triathlons or marathon running. Is there a point of diminishing returns that your certain level of fitness is, you've gotten probably most of the benefit, and the rest you want to do for your personal gain or for your quality of life, or to achieve something for an ego or whatever the case may be, is fine. But as far as your longevity is concerned, there's kind of a diminishing level of return. And where would that be? And is there a point where you can push it to a little too far?
Yeah, to address your question, the biggest bang for your buck in terms of fitness goes from going below 5 METs to above 5 METs. 5 METs appears to be an important point. So our first goal with a heart patient is get them above a 5 MET capacity, all out effort, which means we've got to get them training a little over 3 METs. Then I'm pretty sure if you're regularly doing 3.5 METs, you can beat 5 METs on a stress test. If you say to me, Barry, is there a specific MET level where survival benefits appear to plateau? It's about 10 METs, 10.5 METs. That's equivalent to stage 3 of the Bruce Treadmill protocol, 3.4 miles an hour, 14% grade. So if I have a patient who can do 3 minutes at 3.4 and 14, I know they've got a 10 MET capacity. Generally, they have the best overall survival. Same survival as somebody with a 14 or 15 MET capacity, believe it or not. To your last point, is it possible to get too much of a good thing? I believe it is. And if you go as a physician to the March issue of Circulation 2020, we did a specific paper reviewing all these things. And the take-home message there is that extreme amounts of exercise, that is high volume, high intensity for many years, increases the level of coronary calcium, which is not advantageous, and increases the likelihood of developing a heart rhythm irregularity called atrial fibrillation, which you're well aware of can lead to a transient ischemic attack or to stroke. So it may be possible to get too much of a good thing.
So, going back to the Motor City analogy, if you've got a ZR1 Corvette, it's great, but if you're hammering it constantly all the time, it's probably not going to last as long as if you give it, some better treatment. And once in a while, go to a track, by the way. I'm not encouraging speeding, by the way. Go to the M1 track nearby here and do it legally. That being said, you did mention something that was very, I think, impactful to me when you mentioned that essentially, if you're walking, because you mentioned, and we talk about walking all the time, if you can't do anything else, the blue zones, wherever you walk, that brisk walking at around 3 to 3.5 METs.
That's correct.
If you're able to sustain that you said you're predicting that they probably can have a maximal of that over 5 threshold that you're talking about. So
on a stress test, that's exactly right. And if you say to me, Doc, okay, what is that 3.3, 3.4 METs? It's walking on the level at 3 miles an hour. Or if you say to me, that's too fast for me, then I'd say to you, go at 2 miles an hour up a 3.5% grade. Both of those are equivalent to 3.4 METs, which is a great training level, which almost guarantees me if you can do that regularly, you can beat 5 METs on an all-out stress test. So you get out of what we call the bottom 20%, the least fit, the least active, the highest risk cohort. So the first priority is get my training above 3.5 METs.
And in light of this whole perceived exertion concept, would that be, as they say, where you could have a conversation with someone, but you could barely finish a sentence and you'd rather talk to them later?
You should be able to carry on a conversation at those levels. So in general, when you talk about perceived exertion, we're generally looking for overall ratings of 11 to 13 on the Borg scale, which corresponds to fairly light to somewhat hard, taking into account overall fatigue, breathing, and everything else.
So people, what we're saying is you can do this. Get out and take a walk, and if you have a treadmill and you have joint issues and walking fast is an issue, Dr. Franklin saying, well, just increase the increment a bit.
You can still hit 3.5 METs, keeping it at 2 miles an hour with a 3.5% grade. Correct.
I have to admit, I have a hate-respect, really, I won't call it love-hate. It's a hate-respect relationship with the treadmill. I tend to take advantage of parking garages when they're empty in the morning, and I use the inclines up the parking garage. So anyway, so there, in other words, you can find a way. If you have a will, that there is a way, and it's not that hard to get the benefits. There are, in coronary disease, there tends to be a lot of a cacophony of confusion. Can you bring us back to the core issues that drive the risk for the biggest killer, and even in 2020, coronary disease? What are the foundational issues that drive coronary disease? Just so we're
if you go back to the journal Circulation 2011, because I showed the slide, there's a guy at Harvard, I don't know if he's still there, Darius Mozaffarian, very, very well known. He came up with a triangle showing coronary disease, and at the very top, it's death due to cardiovascular disease. But you're right, down at the bottom, there's a foundation. And he said there's 3 foundational factors, which I agree with, and you probably agree with: poor diet, physical inactivity, and cigarette smoking. And those factors, alone or in combination, over a period of time lead to risk factors. And those risk factors over time lead to what we call subclinical coronary artery disease. And they ultimately manifest as heart attack, sudden cardiac death, or anginal equivalents. So yes, those are what I would refer to as the foundational factors. And if you want, we can talk about those.
It's something that our founder, Dr. David Katz, calls feet, fork, and fingers, right?
Okay.
Feet for physical activity, fork for what we eat, and fingers for smoking.
Yeah.
Absolutely. We've had a reduction in smoking. It's like we've flattened out a bit, but we certainly have had a significant reduction. I think it goes to show you how difficult it must be for those, and compassion for those people that I don't think anyone does not know that smoking is an increased, well, not only for heart disease, but for cancer and advanced aging, even dementia. Arguably, all of these things probably have a single link, cardiometabolic disease. But how much of, where is smoking in terms of contribution to heart disease today versus, let's go back, where doctors were smoking and recommending that smoking was good for you?
Yeah.
Made a big impact.
There was a time when we had about 45–50% of the population who were cigarette smokers. We're now down to less than 20%. It's even far less among physicians and highly educated individuals. But I think the point I'd still make is that even though that is relatively small, 20% or less of the population, do you have any idea how many people we lose each year to cigarette smoking?
That's a great question, putting me on the spot. I'm going to give a real guess here. Okay.
Well, that's fine.
I'm going to guess and we're adding in cancer, correct?
Yes. Mm-hmm.
So if we're going to add in cancer, lung cancer, the biggest killer, not necessarily the highest numbers, but the biggest killer, I'm going to have to throw my hat in somewhere around 400,000 to 500,000.
Well, that's a darn good guess. It's 540,000 to 600,000 people. Let me ask you another question.
Oh, no.
We're so preoccupied with COVID. How many people have we lost in the last year and a quarter due to COVID?
We're right around the 600,000 mark or so.
That's the point. And people say, wow, every year we're losing 540,000 to 600,000 to cigarette smoking. So due to lung cancer or cardiovascular disease. So it's something that has to be a key goal in any preventive medicine program, is to get people to stop cigarette smoking. And there are good data to suggest that if you can get people to stop smoking, longevity increases. Lifelong smokers lose on average 10 to 12 years, period.
Mm-hmm.
10 to 12 years of lifespan.
And we already have something on the order of the last 10 to 15 years of a typical American or even Canadian's life spent in disease. And I want to give an analogy for people who say, well, my uncle smoked and he was 105. If you took 20 people and you blindfolded them and you asked them to walk across busy I-75 and 2 of them made it, was it a good idea for them?
That is a great analogy. And I use the same type of analogy when people say, well, I had an Uncle Jesse and he smoked and he was 86 when he died. My answer is Uncle Jesse is an anomaly. Don't base your decisions on lifestyle due to one person. I study thousands of people. When you study thousands of people, on average, they lose 10 to 12 years.
It's unbelievable.
Yeah.
How can we not discuss in a true health initiative forum like NOTeD, the role of food? We are swimming in something I've coined and just published in the American Journal of Health Promotion, crap, but I want to be clear, it's not a pejorative, it's simply calorie rich, refined, and highly processed, CRRAHP. So it happens to sound like that other word, but it technically is calorie rich, refined, and highly processed. It surrounds us, we're swimming in it, it's tempting. We can't deny that it tastes, I would say that healthy food can be made to taste very good as well. I mean, by phenomenally well, but let's be honest, it's in the gas stations, it's in the Bye Bye Baby, it's in the movie theater. It's wherever you go. It seems like it's constant and beverage calories and fatty confined feeding operation, fatty meats, etc. But nevertheless, can you bottom line it for us? Does our food matter? Is it that complicated? Is some weird diet that we have to follow to be healthy?
The problem is many Americans are addicted to salt and high sugar products. It's as simple as that. And if patients sometimes say to me, if I'm going to do one thing, what do you recommend? You may disagree with me. My answer would be 6 to 8 servings of fruits or veggies every day, number one priority. And then I say, don't leave the breakfast table unless you've had 2 or 3. They said, that's impossible. I said, I do it myself on a day-to-day basis. Well, give me an example. I had Cheerios this morning. I threw some blueberries on there. I had a glass low sodium of V8 vegetable juice, not a big glass, a little glass. And I had a banana. So the blueberries, the V8 and the banana, I got out the door with 3 of the minimum 6. I'm telling you, it's not impossible.
No, not at all. And I completely agree with you. In fact, I think we have evidence from both the, not only EPIC, a large perspective study of in Europe, but not only for cancer, which is what the C stands for, but cardiovascular disease as well. And we had a chance to interview Dr. Michael Gervin, and one of the co-leads for the Bolivian Chimane, right? This group of, I say hunter-gatherer, and he stops me. Excuse me, let me get this straight. It is forager, hunter, horticulturalists that live in the Amazon, and they boated down the Amazon River, hundreds of them, to have coronary calcium scores performed. And they don't necessarily have a wide variety of what they eat, but they eat a lot of plants. And the point made via EPIC too is variety is nice, but the volume you eat is the most important. And it's not that hard. It doesn't have to be exotic, weird fruit, and this fruit has this antioxidant, this, that, the other thing. Pick your ones that you like, put them on rotation, as Dr. Franklin has done with his low sodium V8. Thank you very much for mentioning.
Yes.
It's not bad.
That's correct. Now, the other point I would make, and one of the people I really admire in the field is a guy by the name of Dr. William C. Roberts, who you probably know. He's the editor of American Journal of Cardiology. He's 88 years old. He's still working full-time as the editor of the American Journal of Cardiology and Baylor University Medical Proceedings. And he said 40 years ago, people said he was crazy. We fatten our cows and pigs, we kill them, we eat them, then they kill us. How sobering. And we have the good data that if you have one food group that is really bad for you, cancer and heart disease, it's processed and unprocessed meats.
Yes, we in fact, when I do grocery shopping tours, I frequently stop at the meat section. I go, look at that marbled meat. We give it a value of prime. And what's happened is that animal has been stuck in a box, overfed, so fattened that the fat is actually now being stored in the muscle.
Yes.
If you check the insulin level or the cardiometabolic health of that animal at slaughter, I would not doubt if many of them had prediabetes, maybe even full-blown type 2 diabetes, and certainly they would have cardiometabolic disease, because that's what it looks like. So that's what you're eating. And if you think it tastes good, it's your choice. I'm just here to give you information, but absolutely, I agree.
Yeah.
One of the and I'm trying to, I think it was Dr. Kim Eagle, speaking of number 2 in Michigan for cardiology, University of Michigan. Sorry, Dr. Eagle. Mentioned that the concept of requiring a stress test before a sedentary person became physically active was a bit of a challenge in his thinking, in the sense that the risk of sitting is so high that if you continue to sit, we may just as well still get a stress test to make sure continuing to sit is safe.
Yes.
But nevertheless, what is the greatest risk for a cardiac event during physical exercise? Because people are concerned with that. And even in a state like Michigan, when we have people going out and shoveling the first snow and so forth, if you could comment on that.
Yeah, I think the risk of exercise, if you do it right, is very, very low. First of all, I don't care what you did 40 years ago. If you're 60 and you said I ran track, that's fine. You can't start running track again because there's a good likelihood, very high likelihood, you've developed cardiovascular disease over the last 40 years. Study at the Cleveland Clinic showed out of all their database, 85% of all Americans over the age of 50 already have atherosclerotic cardiovascular disease. I'll say that again, 85, if you're 55 and you say, I don't think I have it, I say, I can look at you and say, I'm 85% confident if we actually look, we're going to find fatty streaks and plaques in your coronary arteries if you grew up on some of the products that we see here today. So the first point is assume you've got coronary disease if you haven't started an exercise program, and start walking. Always 2 to 3 miles an hour, very, very low level. Don't start running or jogging. To answer your question, exercise is most dangerous for people who have been habitually sedentary or inactive, and after many years decide they're going to start jogging again or running around the block. Start walking, gradually increase your intensity over the next 2 to 3 months, not days, months. And so you're walking at 3.5, 4 miles per hour. As long as you're not feeling any discomfort, any anginal symptoms or whatever, you're doing fine. You can progressively increase that. The biggest risk is in people with known or suspected cardiovascular disease or structural cardiovascular disease. Big enlarged heart called hypertrophic cardiomyopathy who suddenly start high intensity exercise. Those are the people that get in trouble. I'm also in agreement with the fact that no, everybody doesn't need a maximal stress test if they follow that type program where they start walking. And if they have developed symptoms, then stop the walking program. And then you may need a stress test to determine if you've got underlying coronary disease. But I agree completely. Everybody doesn't need a maximal stress test to start a conventional walking program at the age of 50, 55, 60.
Is some of the gradual buildup also because the blood pressure response is more risky? It can spike higher the less in shape you are. And these asymptomatic plaques, these plaques in your coronary arteries, I sometimes call them acne of the arteries because they're microanatomically like pimples, but they're not enough to cause a symptom, but they could be soft. And if you all of a sudden start exercising, and so I'd like you to go back to the first snow of the year analogy, that can literally put pressure on a plaque that could cause a rupture, of which now you go from 30% no symptoms to 100%, with the rest of it being a blood clot. Yeah, and that slow buildup allows your blood pressure to not necessarily spike so high if you were to go straight up to 6 mets versus gradually building up to 6 mets.
That's exactly correct. And it highlights another important point, and that is the vast majority of heart attacks occurred blockages that were 30, 40, 50, 60% on a recent angiogram, not the 75, 80, 85% lesions. So that's also one of the reasons why I, and maybe you over the years, did a stress test on somebody, and we said, geez, everything looks good. And then I've had a couple instances where somebody was knocking at my door and said, Doc, do I look familiar? And I said, yeah, you do look. So you did a stress test on me 6 months ago. You said everything was fine. I just got out of the coronary care unit. How can that be? It can be because the stress test won't pick up a 30, 40, 50, 60% lesion, which can suddenly rupture and occlude, especially with vigorous, unaccustomed exercise in somebody who has known heart disease or suspected heart disease.
So when we have in the area here in Michigan, where we are, that first snow of the year, what happens in the emergency rooms?
The emergency rooms are inundated with usually middle-aged to older men with known or suspected coronary disease. Our research at Beaumont suggests they're oftentimes overweight, oftentimes have multiple risk factors, and oftentimes habitually sedentary who go out once a year to shovel heavy, wet snow. They're also doing it, by the way, in the early morning hours when we know there's a circadian variation for heart attacks. So there's already a heightened risk at 6, 7, 8 o'clock in the morning. Snow shoveling also involves upper body work, which is more taxing than lower body work. It involves breath holding, what we call Valsalva maneuver, which can cause big spikes in the heart rate and blood pressure. It can involve isometric exercise, which involves straining. It can involve the cold temperatures, which cause vasoconstriction and raise the blood. You're not going to feel necessarily the blood pressure going up, but it can cause that. It can also cause coronary constriction. So as George Clooney would say, it's a perfect storm. You got all these things happening at the same time. And last point I'd make is when you're on a treadmill, your legs are moving, so you're promoting blood back to the head, to the heart. Oftentimes with the snow removal, you're literally standing still and the legs are motionless, so blood tends to pool in the lower extremities. So for all those reasons, there are virtually hundreds, if not thousands, of fatal and non-fatal events in middle-aged and older people who were shoveling heavy, wet snow. We even get heart attacks coming into Beaumont and people who were using electric snow blowers.
Interesting, because it sounds like you're saying it's silver buckshot. They still have the cold. They still have to push the thing. So,
Yep.
but you led me to a question that number one, I think first and foremost, just to repeat something you and I have talked about, and I can't remember who you said first quoted this, but the first symptom in coronary disease in 1/3 of cases is sudden death, because you don't get the warning that the plaque is there. When it ruptures, that's the problem. They're still going to want to shovel though, Dr. Franger. What do you recommend as a way to go about it in a safer manner? We're not that close to snow, I realize, but someone could be watching this then and write this down, because this could save your life, people. Please listen to what Dr. Franklin said.
Well, once again, for people at high risk, middle-aged or older individuals, who have one or more risk factors, I don't think they should be shoveling. If they're pushing the snow off a step or something, that's different. Lifting and throwing heavy, wet snow. Our studies at Beaumont show that the heart rate and blood pressure get up equal to or greater than maximal treadmill testing. So can you imagine have a maximal treadmill test outside with the cold, on top of the cold air and everything else? Once again, it's the reason why we have cardiac events every year during that activity. And for those individuals, I'd say if you can hire a neighborhood kid or the local plow for a few $100s for the year, let them be out there at 4 or 5 o'clock in the morning. Get in your car, open the garage door, and drive to work. It's truly a dangerous activity.
Okay, and I guess if they feel compelled otherwise, it would be small amounts. Get warm. Only shovel as much as you need, and get the heck out of there. And it's only if you must, I guess.
Yeah, I'd agree.
The question about aspirin. The FDA has, if I'm not mistaken, you can correct me, made it pretty clear that it's not just so clear cut. Everybody just take an aspirin and it's fine. There's a bleeding risk. It could be in your stomach. It could be in your brain. What is the patient where the threshold of benefit outweighs the risk? And then maybe we could talk about what you might do with baby aspirins or whatever regular aspirin in the context of an acute event. That's a separate question about chewing the aspirin. How do you do it? But on the daily basis, there's still a lot of belief that taking a baby aspirin on a daily basis for anyone is beneficial. The data on that is not quite as clear cut. Where does reality make sense?
No, there were 2 landmark studies showing the risks outweigh the benefits for what you're referring to as primary prevention. Somebody who's never had a heart attack and is trying to prevent a heart attack, the bleeding risks are fairly high, and we don't have good evidence that therapy really prevents heart attacks, initial heart attacks. On the other hand, for secondary prevention, people who've already had a heart attack, have had an angioplasty or bypass surgery, there's very good evidence that the benefits outweigh the risks. So in general, and by the way, how much aspirin do you need? We used to say a full aspirin, then it got down to 160. Now most studies say you get most of the benefit with the 80 milligrams.
I had a professor at Wayne State, I don't remember who it was, who said you can probably lick an aspirin. That's obviously exaggeration, but to your point, the issue of weight is always controversial, right? We have such a massive number of people combined overweight and obese. And frequently, and frankly, many people, and you know this as well, with myself having binge eating disorder, almost losing my life to it, lost my youngest brother despite gastric bypass surgery, all of the shame and everything else that came with it. We have to be very sensitive to when we're talking about human beings here. And in fact, before I guess ask the question, I also like to emphasize that wherever you're starting from, you'd be surprised how much benefit there is from losing just a modest amount of weight. The thought that I need to lose 100 pounds, while that might be nice, and some people have achieved it, I think a 5 to 10% reduction, the data on it is pretty strong, but nevertheless, we can't hide the sun with our finger. It is still a fact that there is an issue of body composition, if we want to use maybe a better term, in America. What is that relationship between BMI and maybe a little bit of differentiating BMI versus body composition? As you know, I'm kind of getting to the skinny fat question, and mortality.
Yeah. To your first point, I oftentimes cite a study by Blackburn that was published in American Journal of Clinical Nutrition, where Blackburn and colleagues showed losing just 5%, if you're overweight or obese, losing just 5% of your body weight confers very significant health benefits. So when people are saying, what should be my goal? My thoughts, an initial goal, you may want to lose 100 pounds, but initial goal, 5% of your body weight. So, for the 200-pound person, a 10-pound weight loss or so could be very, very significant in terms of health benefits. You're exactly right. BMI doesn't necessarily correlate beautifully with body fatness and so on and so forth. We have good evidence that people who have large amount of fat stores in the abdominal area have higher rates of cardiovascular disease, higher rates of cardiometabolic disease. And then lastly, if you say, what's the relationship between BMI and all-cause mortality? I would describe that as a U-shaped curve. People who are very, very thin, BMI less than 18.5. I saw a woman the other day whose BMI was 18.9 or something like that. And I said, you could stand to gain 5 pounds or 8 pounds because you're very close to 18, less than 18.5. There's a very high rate of death. And over, not 30, but over 35, there's a very high risk of death. So the extremes of the continuum, I don't wait to 35. I've arbitrarily in my counseling, when I see a BMI of 31, 32, where they're approaching that 35, then I say purposeful weight reduction, very, very important. We also have good data, however, to suggest, especially those individuals who are overweight, maintain that fitness level, because we have good data from Stephen Blair and others that show that people who are overweight, who are truly fit, can have lower mortality rates than people who are very thin, who are totally sedentary and unfit. And Chip Levy will tell you that as well.
Absolutely, yes. So when we are talking about some of the other factors that we haven't necessarily spent time on yet, other than how blood pressure is affected by physical activity and its potential to cause a plaque rupture, and blood pressure and cholesterol, I like focusing in on these core simple issues, and people get all into the periphery and the shiny object when we have these really core issues of blood pressure and cholesterol. And while I think it's fine to control blood pressure with medications, the question I have would be, what is a truly controlled blood pressure? The numbers are changing. Many people just think it's if I'm at 120 over 80, that's perfect. Maybe not. What is, when it comes down to a sustained resting blood pressure, what is the zone that Dr. Franklin would like to see his patients at?
Well, you have to weigh getting the blood pressure too low with becoming hypotensive and experiencing orthostatic episodes and so on and so forth. I used to tell people anything under 140 over 90 was good for you. That was 10 years ago. That was before a very famous New England Journal of Medicine trial called the SPRINT trial came out, where they looked at hypertensive people who did not have diabetes, and they randomized them to two groups: aggressive blood pressure lowering, 120 or less, or less than 140. So it gets to that question, 140 or 120. They stopped the study early. They stopped the study early because those who were getting 120 or less systolic pressure had 25, 28% lower death rates. So in general, lower is better if they can tolerate it from an orthostatic standpoint. I also get the same question relative to heart rate. There are good studies, many studies that suggest lower is better. So in general, when a heart patient says to me, where should I be? My answer is 55 to 70 is where I'd like to see your heart rate, and certainly not 80 or 85 or 90. Keep in mind, an exercise program in and of itself will typically lower the resting heart rate by 10 beats. That's pretty significant.
As a matter of fact, as you mentioned that, and we have people who are now, and frankly, even for the convenience, not necessarily wanting to drive and go places any more than is necessary, you and the team have written a booklet on cardiac rehab, which really could apply to anyone, even preventive. I'm going to call it prehab, preventive rehabilitation. If you don't mind, tell us a little more about it, how people can get it, and what are the principles in it.
This is what it looks like. It's called Home-Based Cardiac Rehab, Barry Franklin, Wymo Zoo. And what we did, we wrote this in part because of COVID and the programs closing and so on and so forth. And we emphasize that people can oftentimes do a lot at home and should be doing more at home because it's readily accessible, easily available. This is a booklet that the individual booklet is $10, but the publisher is generous enough to say, if you order 10 copies for your patients, it's $3 a booklet. It's called Healthy Learning is the publisher. So they go to healthylearning.com, or if they want to call a number, it's 831-372-6077, 831-372-6077. If they order 10 or more copies, they buy them at $3 a piece. These are a great resource. We cover everything from diet to exercise to pharmacotherapies. And I think those are really, really important things people can learn.
And it looks like it's a high impact read. It's not a heavy read. It's something that's got practical language.
It's written for lay people.
Because I have it, and it's really great. Again, it's healthyliving.com.
Healthy learning.
Healthylearning.com.
Right.
Healthylearning.com or 831-372-6077.
And it's called Home-Based Cardiac Rehab.
Home-Based cardiac rehab, Dr. Franklin and Dr. Zhu, Z-H-U, if I'm not mistaken. As we are rolling towards the end here, there's a couple of things. First, you stole my thunder when you talked about your breakfast, because I ask almost every guest, hey, what do you eat for breakfast? But I guess I'll have to ask, is we're focusing on here, how does Dr. Franklin stay physically active? What is your daily, ground level, granular, concrete routine that anyone could understand? What do you do?
Yeah, my wife and I have a 4-mile course. So we have a walking course that we follow usually at least twice a week. And then my wife got ticked off at me because I was using the treadmill here many years ago, and I'd stay till 7, 8 o'clock at night. And around the holidays, she said, I bought a gift for you. We have a Precor upstairs in the bedroom. You can adjust the speed and grade. I actually like it very much. And I can get a really good workout in about 25, 30 minutes. And what I do is I do a modification of the Bruce treadmill protocol. My warm-up is 1.7 miles an hour, 5% grade for 6 minutes. Then I do stage 1 of the Bruce protocol, 1.7 and 10% grade for 6 minutes. That, by the way, is 5 METs. Then I do 2.5 and 12% grade for 6 minutes. That's 7 METs. And then I do 3 minutes of stage 3 of the Bruce treadmill protocol, which is 3.4 miles an hour, 14% grade, which is 9.5 to 10 METs. My perceived exertion at that is around 14 or somewhat hard to hard, and that's it. And it tells me that as a guy 73 years of age, if I have to do a maximal stress test, I can do it safely without a problem, no chest pain or anything like that. And I'll probably be in the neighborhood of 11, 12, 13 METs as a max capacity, which is far beyond the 10 METs that you need for optimal survival. So that's what I do.
Wonderful. Host prerogative. There are a couple of questions I want to get in at least quickly. Can't help. I had a coronary calcium score done at Beaumont, Royal Oak. I'm happy to say mine was 0 here as I approach 53 this month. But what is your perspective on that as a screening test for where there are no symptoms and someone is not clearly low and obviously not already had a stent in our, there's no sense in that case.
You know, the physician who oriented me, really, who taught me about it, was Dr. Harold Friedman at Beaumont. And he said his clinical experience is that it's very, very valuable. It provides additional independent and additive information. And the studies are pretty darn clear. If the coronary calcium score is 0, like yours, the likelihood over the next 10 years of suffering an acute cardiac event, angina or a heart attack, is well less than 1%. Well less than 1%. If, on the other hand, your score is 400 or higher, you've got a 50% likelihood over the next 10 years of suffering a coronary event. So it has very strong prognostic significance. We say it provides independent and additive information along with cholesterol, blood glucose, blood pressure, BMI, and so on and so forth. So I think it's a worthwhile test, and many hospitals are now doing it for about $100. If it's not covered, it's worth it.
And Beaumont is a place that can do it, and I think hopefully soon there would be potential coverage. Second to last question, you just brought it up. We haven't talked about it a lot. Cholesterol, the controversy. It's not the factor that matters. I'm going to try to play the host and be neutral here. Except to say that I have to have some, as an internal medicine and lifestyle medicine specialist, cholesterol does matter. What is, when Dr. Franklin looks at a patient, where do you, for primary and versus secondary, they've already had an event, where do you stand in terms of where you like their LDL, or maybe non-HDL? Maybe that's the marker that you use, but you can comment either way you like. Where are you in terms of, does cholesterol matter, and where would you like it in your patients?
Well, the lesson I sat next to Dr. Roberts on a plane one time, and I asked him about cholesterol, and I'll never forget, he told me this 20 years ago. He said, Barry, remember the rule of 40. And I said, what is that? He said, Barry, for every 40 points you lower your cholesterol, you reduce your risk of a heart attack in half. So if the cholesterol is 280, take it to 240, you cut your risk in half. Take it from 240 down to 200, you cut your risk in half again. Take it from 200 down to 160, you cut your risk in half again. And he points out that if the total cholesterol is less than 150, there's very little evidence of any kind of progression of coronary disease. So for somebody with known coronary disease, our goal is 130, 140, something along those lines. You may need a statin to accomplish that. You may need a PCSK9 inhibitor, which is a very, very powerful drug for further lowering LDL. Although they've gotten away from numbers, I personally believe for primary prevention should be under 100 LDL, for secondary prevention under 70.
Fantastic. And what would you say are things that strike you so to the core in terms of indelible memory, in terms of quotes or bottom line type of messages that resonate with you, and also that you have been able to find resonates with others? What are some, and this would be a great way to leave the interview and have people have this insightful, indelible quote or message that you might think is impactful.
Well, it's a perfect question for me. I end every consult with a quote by the late General Norman Schwarzkopf. You remember General Schwarzkopf?
Storm and Norman.
Storm and Norman, you're exactly right. And I remember he was once asked, and this really got my attention, Dr. Rafai, General, how do you respond to an enemy attack? And his response was one word: counterattack. I contend when the enemy is heart disease, the strategy is no different. How do you counterattack? Aggressive lifestyle modification, risk factor modification, healthier diet, regular exercise, no cigarette smoking, and taking prescribed medications, whether it's a beta blocker, aspirin, ACE inhibitor, or a statin, or combinations thereof. We have good evidence that the lifestyle provides independent and additive information, independent and additive benefit for people who are taking those cardioprotective medications. So if you want the maximum, combine lifestyle with pharmacotherapies.
And the lifestyle, I think you said before, can be summarized in different words, but similar to as Dr. Katz says, feet, fork, and fingers, right?
Yeah,
Fruits
that's a
and
great analogy.
Fruits and vegetables, not hard. Get out and walk. Now you know how. If you smoke, I might throw in 1-800-QUIT now, or just talk to your doctor or find some way. We know it's hard. It's not easy, but still it's worth it. Dr. Barry Franklin, Director of Preventive Cardiology and Cardiac Rehab at the Beaumont Health System in Royal Oak. Then the health system itself, #1 in Michigan, U.S. News and World Report, and also on the board of directors for the American Society for Preventive Cardiology, and my mentor, a man who helped teach me when I was just a little nub of a resident. I can't thank you enough for this. And of course, on the THI Advisory Council. Thank you so much for your time, sir.
Thank you, Dr. Rafai. My pleasure to be here. Thank you.